Good morning, good afternoon, good evening, wherever you may be joining. Thank you for tuning in and for coming in person for this IAS Distinguished Speaker Series presentation. Really excited about this speaker. So my name is Adam Leventhal. For those of you who don't know me, I'm the director of the USC Institute for Addiction Science. The Institute, which was established here at USC in 2018, its mission is to advance science, education, and community engagement and clinical activities related to addiction. One of our key missions related to community engagement is dissemination of key evidence that's relevant to advancing addiction science and practice. And that's why we're here today for this Distinguished Speaker Series talk. So I'm honored and thrilled to announce that we have Dr. Albert Garcia-Romeu here visiting us. So Albert, he is an associate professor of psychiatry and behavioral sciences at Johns Hopkins University School of Medicine. His research examines the effects of psychedelics in humans with a focus on psilocybin as an aid in the treatment of addiction. He has his doctorate in psychology from Sofia University in Palo Alto, where he studies self-transcendence, spiritual experiences, and the relationship to mental health. He also completed a postdoctoral fellowship in behavioral pharmacology at Hopkins Behavioral Pharmacology Research Unit, where he trained in clinical research in psychedelics. And then he has joined the faculty, and he's been there ever since. I think currently his role is the associate director at the, I don't know if it's the world's only, but it was at least one of the first centers at a major university for psychedelic and consciousness research. Extremely innovative. Him and his team has been leading the charge. He does a lot of different studies addressing the intersections of psychedelics and health, mental health, and addiction. And he also has a number of service roles too, and has been on the board of directors for the College on Problems of Drug Dependence, published numerous articles, gotten lots of grant funding. So we're just really excited to have Dr. Albert Garcia-Romeu here. Let's give him a warm round of applause. Thank you.
Great, thanks very much, Dr. Leventhal, for extending the invitation. Thank you all for having me. And yeah, my name is Albert Garcia-Romeu. I'm going to talk a little bit about psychedelic therapies, primarily for addictive disorders, but there's just been a lot of new data over the last decade or so. It's accumulated rather quickly. So I'll cover a lot of different types of information today. And I apologize because it used to be easy to put a lot of this information into a short talk, but now because there's so much work, it's really hard to get it all in there. A few disclosures: I paid advisor to a couple of companies in this space, and we've gotten research funding from both for-profit, nonprofit groups, and also from the NIH and the Department of Defense. But that has no bearing on what we're talking about today. Mainly just going to be talking about the pharmacology, just so I can be clear about the terminology of the drugs we're talking about, because that can be a little cloudy and muddy sometimes. I like to talk about the history because the history of these drugs is as interesting to me as the science. And then we'll talk about the clinical research mechanisms, because I think that's a huge question right now. And then we'll have questions at the end. So all the drugs that we're talking about are basically broadly considered hallucinogens. It's a weird term. I actually published a paper this morning about this because I don't like this word hallucinogen. Word psychedelic is the one that's often used. People also use all sorts of other weird names like these. And so these are the ones that are often used commonly to talk about certain types of drugs. Entactogens or empathogens, those are drugs like MDMA. I won't really talk about MDMA today just because it's too much material, too far afield. But I will talk a little bit about these dissociatives, specifically ketamine, because that is a really interesting substance we've known about since at least the 70s. But since the 90s, we've known more about the psychiatric indications that it can be used for. And since the 2000s, we've seen more of this really interesting work on addiction treatment with dissociatives, particularly ketamine. And the classic psychedelics, that's what I've been studying for the most part over the last decade. So we'll talk about those. But all of these drugs seem quite curious because they have these transdiagnostic potentials, meaning we can apparently use them not just for one kind of disorder, but for a few disorders, and including a few different types of addictive disorders. And we even have people now that are thinking about trying to use these in like behavioral addictions, like gambling and compulsive internet and pornography. So there's a lot of potential here that has not been studied. And so, but I will talk a lot about what we call psychedelic assisted treatments or psychedelic therapies. It's a weird term, but the main thing I want to convey there is that it's not just the drug that is doing the heavy lifting, like a pharmacotherapy. It's almost always like a package deal. So we'll have some kind of supportive care before, during, and after the drug administration that we think helps facilitate some of the efficacy. We don't know that for sure, but it's an open question in the field. This is a great paper by Dr. Michael Bodenschutz, who's done a lot of seminal work in this area. But he really nicely outlines this sort of like all these interactions and these moving parts that come together to create some of the therapeutic effects that we're looking for with these psychedelic therapies. And the main thing I just want to point out here is that there are some real biological effects that are quite interesting on serotonin, glutamate systems, and other brain-derived neurotrophic factors that we think are influencing some of the effects from a biological standpoint. And then there's also all this other stuff that we've seen historically, that we know these drugs create these very florid psychoactive effects. And we also think those seem to be contributing to some of the other benefits that we're ultimately looking for. So I'll talk about both of those kind of two sides of the coin later. As I mentioned, the main dissociative that we'll talk about today is ketamine. There are other interesting ones like dextromethorphan and nitrous oxide. And obviously, you probably have heard about Spravato, which is an enantiomer of ketamine, which is a newly approved medicine for treatment-resistant depression. But these, for the most part, all you need to know is we think they're NMDA antagonists, and that's in the glutamate system, and that seems to be leading to some of the therapeutic effects. The classic psychedelics are real interesting drugs. There's many of them, and the main thing that we think is driving their effects is the serotonin 2A receptor, but that's also not 100% clearly established. But a lot of these are just natural substances. So DMT, psilocin, which is what psilocybin is broken down to in the body, mescaline, these are found in like plants and fungi. And so people have known about them for a very long time and have used them, predating science and written history. But you can see obviously that there's a very, very strong similarity structurally between serotonin, which is one of our major mood regulating neurotransmitters, and psilocin and some of these others. They have that indole structure, which is this benzene ring with this other five-sided structure right next to it. So as a result, all of these drugs stick to our serotonin receptors, and that we think the primary site of action is that 2A receptor specifically, which we don't really know what it does. Psilocybin, which I'll be speaking about for the most part today, is found in about 200 different species of mushrooms. They grow all over the world. Most of them are in the psilocybe genus. And we just know from historical records that people have been using these and encountered these mushrooms way back. These mushrooms here are from Mayan ruins in Guatemala. They're about 3,000 years old. And they just show that for a long time, people have considered these psilocybin-containing mushrooms as important culturally. Exactly how and why they were used is unclear. We do have some early historic records. This is from the Florentine Codex by the Franciscan friar Bernardino de Sahagún. And basically, he encountered the Aztec people in central Mexico. This was about the 1520s at this point when he arrived. And what he said was, these people would have these nighttime ceremonies where they would take these mushrooms that seemed to be intoxicating and cause visions and provoke sensual behavior, and that they were used during these ceremonies where people would dance, sing, and weep, and in the morning they would talk among themselves about the visions they'd see. And so Not really clear what was going on. This guy actually did a lot to document the lifestyle. They call him the first ethnographer of some of these indigenous peoples here in the Americas. But we've had these written accounts of the use of psilocybin-containing mushrooms as early as the 1500s. But modern science doesn't know anything about psilocybin mushrooms. Some mycologists, people who study mushrooms, had encountered the mushrooms, but we didn't know what the psychoactive components were. We didn't know what was going on with them until 1955, roughly. And so that's relatively recent if you think of it in the long scheme of things. And really what happened was this fellow here, which is Gordon Wasson, who's a banker, but also a mycologist, basically someone who would travel around the world to look for rare and exotic mushrooms, had heard about some that were in the north of Mexico. So he went to Huautla in that area and encountered Maria Sabina, who's this curandera, or basically a healer, indigenous healer of that area. And after some discussion, she introduced him to these mushrooms, which you can see here documented. Wasson later wrote about this in Life magazine, which, as you can imagine, this is a big publicity. It created a lot of problems, unfortunately, for Sabina because it kind of ended up causing a wave of psychedelic tourism, if you could believe that, all the way back into the 1950s. This was predating the hippies, but this was when the beatniks were around. And so they were still interested in looking for drugs, and they found her, and they caused some problems. But at least, the good thing that came out of it was that Wasson brought some of those mushrooms back to this fellow here, Albert Hofmann. He had first synthesized LSD in the 1930s, so he was already very accomplished in the field, having created one of the main prototypical psychedelics in a lab. And then he was able to isolate the psilocybin as the principal component of the psilocybin mushrooms. And so in 1958, he published on that. And that was the first time we knew what psilocybin was, from a scientific standpoint, which was pretty cool because then it started to be more frequently studied as of that period. Around the same time, this is the mid-1950s, and like I said, before there were any hippies or any of that type of countercultural movement has happened, but there were other intellectuals like Aldous Huxley and this fellow here who's Humphrey Osmond, who was already interested in LSD, mescaline, doing scientific research with these drugs. And so at the time, everyone called these psychotomimetics. Basically, the main thought behind them was that they created psychotic thinking processes that were temporary, so they would kind of abate over time. But Osmond was working with people, giving them these drugs. He self-experimented as well, and he said, psychosis is not really the right word for this. He came up with the word psychedelic, which he published in 1957, and that was the first time that word has ever been used or coined. And so that is really the word that has stuck. There are other terms, as I mentioned, but we still use that since Osmond came up with that in 57, sort of in a dialogue with Huxley, who was also interested in this and wrote a book called The Doors of Perception around that time. So before I kind of switch from some of the historical piece to talking about the more clinical piece, I will kind of just highlight, there's a sort of tension here. There's different models or different intentions behind people's use. For a very long time, people were using these in spiritual and traditional ways. We don't know that much about it. A lot of it was kind of pushed underground. There was also obviously some recreational and exploratory use among people who were just curious about this on their own for many years, historically. But a lot of what I'll talk about is really kind of from the 50s forward, when we started to study these seriously from a scientific and medical standpoint. And just from that perspective, obviously we still have a lot to learn. Although we can think of the scientific view as a privilege in some ways, it also has got a lot less history of using these substances. And so it's good to acknowledge that there's also these other ways of thinking about and using these. And in the 50s, what was happening really was, besides neurochemical research, which actually helped spur the discovery of serotonin. So we discovered these drugs before we knew that serotonin was in the brain, before we knew about neurotransmitters. Actually, it was Woolley and Shaw and other guys like that in the early 1950s who discovered serotonin, and that was in part spurred by some of this research with LSD. Nevertheless, there were also people who were trying to use these in therapy, and that included people in places like Europe who are using what we talked about as psycholytic therapy, where we would use like low doses of these drugs to help facilitate psychoanalytic talk therapy. And in the US, there's also this sort of psychedelic peak therapy that developed where there would be a few high doses administered along with supportive care. And that was really sort of the lineage in which a lot of the work that we do now has come from. So usually a psychedelic therapy is going to involve, at least 1 or 2 high doses of the drug, and then there's going to be this sort of built-in net of support around that. And so we'll talk more about that model. But the early research was often promising, including in the substance use space. And this is one of my favorite studies. This is not a huge study, but 74 incarcerated men with a history of heroin dependence in the Baltimore area. This is back in the late 60s, early 70s. And they were basically randomly assigned to a treatment as usual condition, which meant they were released on parole into their communities, and they'd have to come back on parole once a week to provide urinalysis to show that whether or not they were abstinent from opioids. And then there's also this group who got a month-long stay in a halfway house before they were released. During that time, they did some group therapy, and in the midst of that, they would have 1 high-dose LSD experience before they were released. And they followed these guys out for a year after their release, and what they found was that even up to a year later, you can see a pretty good separation in terms of the amount of abstinence that was biochemically verified from opioids. And so this is, some of the early evidence that suggested that we could use these fruitfully in treatment of SUDs. A lot of the other work was really squarely focused on alcohol use disorder. This is a nice meta-analysis from 6 different control trials of LSD for alcohol use disorder, 536 men with AUD who either received 1 high dose of LSD as part of the therapy package, or they received some non-psychedelic controlled treatment. It could have been some other medicine or some other talk therapy. But basically where the favorability lies at the end of the day here is really that the people who got 1 high dose of LSD seem to have about twice as good likelihood of showing improvements in their alcohol misuse at the initial follow-up compared to the control group. And that shakes out pretty well when you line up all the data. But of course, there's a lot of variability in these studies at that time, and I think that contributed to some of the noise. This is a good example of that. This is a really small study, 30 patients in an inpatient alcohol use disorder treatment unit. But basically, they would strap you to a bed, give you a really high dose of LSD, and then they would try to do a psychiatric interview for 3 hours during that process. And then they would kind of follow up with people to see if they got better. Some people got 60 milligrams of ephedrine instead of the LSD while strapped to the bed. And some people got no drugs and they just went through their regular treatment as usual, which was group psychotherapy in a sort of inpatient unit. And what they found was that about 1/3 of the LSD group and 1/3 of the ephedrine group showed improvements in their alcohol abstinence, and 20% showed improvement in treatment as usual. So not statistically significant, not particularly compelling, and they thought, well, this just doesn't seem to work. But a lot of people were talking already about set and setting and how the factors around the drug administration are really important to facilitating the therapeutic benefits. And among them were some of these groups who were working at Spring Grove, which was in Maryland down the street from us in Baltimore. And what they found using a very high dose of LSD with supportive talk therapy, not strapped to a hospital bed, versus a group that got a very low dose as a placebo, that over half of the group that got the high dose is showing improvements, 53% there. This was a big study, 104 patients, compared to 33 in the low dose placebo group. So ultimately, this kind of started to lend some credence to the fact that if you did a supportive therapy as opposed to doing more of a just drug administration process, that would seem to help these drugs be effective. At the same time, obviously, these drugs did become very popular in the counterculture. That created a lot of pushback politically And it really ended up at the Controlled Substances Act, which happened in 1970, 71 in the US and internationally in the United Nations. But basically psilocybin, cannabis, all the psychedelics as well were put on a most restricted class of drugs. Research became quite difficult to do, obviously, and there's a lot of taboo and stigma attached to this that led to basically what was, a slow but steady increase in research, for instance, on psilocybin, really declining to almost nothing by the early 1970s. You can actually see there were years here in the 90s where nobody published anything about this. So nobody was really working on this stuff pretty much, from 1970 until about 1996, 1997. People started to get, interested again. And you do start to see there's like a picking up of steam here around the turn of the century, where now we're at a point where there's just, all this work happening, not just with psilocybin, but with LSD, ibogaine, 5-MeO-DMT, MDMA, and LSD even is, a drug that is right now designated as a, potential FDA breakthrough medication. So, it's interesting that the tides have turned so quickly. And so along with that, we were able to secure some philanthropic funding in 2019 to open this center on psychedelic research that Adam mentioned. We're the first big one here in the US, but there's now a lot of them that are kind of popping up all over, which I think is good because the field is expanding quite rapidly. And so before I tell you about some of the good things we found that we can do with these drugs, I will just talk briefly about some of the risks because I think it's important to hit that. But interestingly, these classic psychedelics, psilocybin in particular, is not toxic. So you can take a big giant bag full of them, and it's not going to cause a heart attack or a fatal overdose syndrome, which you couldn't say about Tylenol or benzodiazepines or opioids. So there is a physiological safety component, but they can cause some cardiovascular issues. So people with certain conditions are contraindicated from getting these medicines. Obviously, they're serotonergic, so they can also interact with serotonergic medicines, sometimes in ways that are problematic. But interestingly, they're not what we think of as addictive in the typical sense. They don't cause this sort of compulsive drug seeking. You may see people with hallucinogen use disorder in practice. They're typically, practicing polypharmacy. They're taking a lot of different drugs. It's unusual you're going to have somebody who's just taking one of these drugs kind of compulsively, the way that you'd see like an opioid user or even alcohol user. But there's a low prevalence of HED, hallucinogen use disorder in general, and that includes people who are taking drugs like PCP as well. Nevertheless, people can become psychologically dependent, so they do take them sometimes in ways that are risky and sometimes abuse them. Some people develop what they call HPPD, or hallucinogen persisting perception disorder, which can be some perceptual problems that reoccur after the drug administration. It seems to be a roughly 4 to 5% prevalence in recreational users, but that's hard to measure. But we don't really see it very much in our research, and so it's unclear why that is. But the main thing, I think the biggest risk is that people with a personal or family history of things like psychotic illness or bipolar mood in particular, I think tend to be the ones who are not good candidates for getting these right now. And the main problem is we know they can induce mania and psychosis in vulnerable individuals. And so as a result, we've developed a way around that, but that's just, I think, a good, fair warning. However, again, when you're kind of looking at these drugs compared to pretty much all the others that we know about, mostly they're considered low risk because of the lack of lethal overdose, and also they're not very, again, habit forming. So it's just an interesting point, although they are heavily restricted. One of the big problems that can happen when people take these is these sort of what we call bad trips or challenging experiences. A nice survey done with about 2,000 people who were asked, just tell us about your worst experience taking psilocybin out in the real world. Does kind of illustrate that you'll see some small but still not insignificant portion of people who are acting in ways that are physically aggressive or violent, having to go seek medical treatment or psychological treatment. And very small numbers, but still, worth noting that report afterwards they have enduring psychotic symptoms, or that they even attempted self-harm or suicide. So this is something that, again, these risks are real and they need to be considered when we're looking at the sort of clinical profile of these. Even in our very nicely controlled lab setting, we had up to 40% in one of the studies that Roland did early on, who reported, feelings of fear of insanity, feeling trapped. So this is something that happens not that uncommonly, typically at the higher end of the dose spectrum. But it's something that we can safely contain in the lab. Whereas if people are out in the world, they can act in ways that are dangerous. They can run into the street, they can become disoriented. I was just reading a really sad story about a kid who ended up, asphyxiating because he picked up a bottle of protein powder and tried to chug it, and while he was under the influence, and he was just disoriented. And his friends were there, but they couldn't help. So it's sad because this does lead to problems, including fatalities, even if it's not physically toxic. The other big risk that I like to just kind of go over is that probably your patients, clients, friends, and loved ones have been reading all sorts of crazy media on, out there in the world that are making them think this is some sort of magic bullet that's going to cure their problems, fix their issues, and that they can go buy it, in some head shop and it should be fine. And so it's really important that people have balanced understanding of what these drugs are, how they can be used, what the risks are. And if they're getting drugs on the black market, obviously, they may not know what they're getting, the dosage. There's obviously still criminal penalties for use and possession. So there's still a lot of risks involved with these. And so we're seeing a lot more, though, of these types of case reports published. Manic episode following psilocybin use, case of prolonged mania psychosis after psilocybin use. Often these are people who are seeking sort of do-it-yourself treatment at home. And I would say a lot of that has been driven by these types of headlines, which are not that helpful. Can psychedelics save the world? And so it's gotten a lot of, push in the media, which can be a double-edged sword, because I also think it ends up causing problems, which, we see. I kind of talked about this a little bit as, borrowing a term from sociology, the Disneyfication of psychedelics. We really kind of strip this down and talk about it as a sort of, fully pleasant and positive experience without talking about some of the risks and harms. And so I think that's, doing a disservice to people from a public health standpoint. And because, if you look at the trends over time, these are the lines that you want to look at, the blue and purple here. But basically adults over 26 and people in general are just using these at a greater and greater rate now, partially, again, driven by some of this media. And so that also leads to things like this, which is increases, unless you live in the Northeast, I guess, but otherwise folks are getting these big increases in their drug busts, so they're getting in trouble and incarcerated for having these. So again, people should be aware that these are real risks. So to talk about some of the clinical research, I'm going to just kind of go through a little bit of this stuff. There's a lot of studies that were published at Hopkins, started by Roland Griffiths and then by others after, and they really started off with healthy volunteers. But as we kind of did more and more of that work, we shifted more towards clinical populations, including tobacco smokers, cancer patients with existential distress, people with major depression. And now we're really looking all over the place in places that you wouldn't even think, like Lyme disease, obsessive compulsive disorder, early stage Alzheimer's. So it's a really interesting time to see the field kind of blowing up in this way. A few words about the therapeutic process. We always do an intensive screening to make sure that people don't have cardiovascular problems or history of psychosis or things that could cause a problematic reaction. We usually have 2 facilitators that are doing this whole process. That starts in the preparation phase before there's any drug administered. Then the dosing, they'll sit there through that, and then they'll do the aftercare as well. And this whole process can last anywhere from 2 to 3 months. And the usual prep period is not just talking about the drug effects, but there's some supportive counseling involved where you're doing a lot of rapport building. And I think that's really important for the safety of the drug administration. The dosing sessions, you usually will have 1 to 3 of these high dose sessions. We do them in a comfortable setting. I'll show you a picture in a minute. And they will last 6 to 8 hours roughly. So People come in around 9 in the morning. They'll be at the door around 4, usually leaving with a friend or loved one, and they're monitored by the facilitators all day. And this is a non-directive period, meaning even though we might use CBT or some other therapeutic interventions before the drug or after the drug, when people are on the drug, we actually don't do anything like that. We ask them to lay down on a couch and they listen to music, and we tell them to just kind of pay attention to what's going on in their mind and their body and to be open to that experience. And so whatever happens, we're kind of there to provide any support as needed. So it looks a little something like this. You know, these rooms, we have 4 of these rooms set up to do dosing sessions at the lab now, and we're running a lot of those in various populations. You know, the early work that Roland kind of pioneered, Roland Griffiths, who started the lab where I work, was recently deceased, unfortunately, but he started with these healthy volunteers. And so, you know, this early work was actually really interesting. They took people who were hallucinogen naive. They either gave them a high dose of psilocybin or a moderate dose of methylphenidate, which is an ADHD medicine with some stimulant-like effects. And the idea was to try to keep some blinding here in terms of the fact that they got a drug and they felt drug effects. But at the end of the day, they asked them about what types of effects were notable to them. One of the big areas that stuck out was really this, what we call this mystical type experience. The main thing that people describe from that is this feeling of unity, like all is one, or there's a sense of interconnectedness. And you know, this happens at just much greater rates after psilocybin than you know, methylphenidate, clearly. And you know, pharmacologically, that was an interesting finding. But you know, what continued to kind of pop out from the data was that, you know, 2 months after this session, or 14 months after the session, when people would come back, they would come back and say this was a really extremely meaningful experience to them, like one of the top 5 most meaningful experiences of their lives sometimes. That often they would talk about positive behavior change that was coming as a result of their experience, whereas that was not really something that you're seeing endorsed frequently after the methylphenidate sessions. And so it kind of pushed the needle in this clinical direction, where work with, for instance, populations with major depression started at our lab and elsewhere. So this is one small study, 24 patients, really showing that a majority of them were experiencing remission or relief from their depressive symptoms, even out to a year after you know, 2 doses of psilocybin with some structured support. You can see, you know, not everybody got better. Some people got better and then, you know, sort of went back into depression. So it's not a cure-all, but for many people, if you're looking at the averages here, almost everyone's kind of ending, you know, much lower than when they started this study in terms of their depressive symptoms. And that's been borne out by these larger studies now. This was like, I think, a 95-person randomized trial, double-blind placebo control, using a niacin active placebo, showing, again, the depressive symptoms, you know, kind of drop a little bit after this niacin, but they dropped a pretty good amount after the psilocybin and stayed down. This is out to about 7 weeks post-treatment. So what's curious, obviously, is that the drug is out of your system in, you know, less than a day, but you're seeing these, you know, types of effects happening for several weeks or even months afterwards. And again, this has been corroborated by people outside of our lab, including, you know, this is the largest study of psilocybin published so far with 233 patients with major depression. And basically, the one high dose of psilocybin, 25 milligrams, exerted significant antidepressant benefit up to 6 weeks after treatment, compared to a very low dose or moderate dose, which were used as sort of active comparators here. This work is also kind of taken a turn for palliative care in cancer patients, showing that it can be done in individual settings or even in group preparation and group settings for cancer patients with existential distress, you know, reducing their depression and anxiety symptoms, which can be really helpful for improving their quality of life. But, you know, a lot of that has helped lay the groundwork for some of this work with substance use disorders, which we all know are very highly comorbid with things like anxiety and depression. And so some of the early work, again, this is from Michael Bogenschutz, 2015, really proof of principle like concept to show, can we do this? Will people go through with the treatment? What happens after the fact? This was in 10 people with alcohol dependence who got 2 high doses of psilocybin and some motivational enhancement therapy. And they followed them out for about 9 weeks and found a significant reduction from baseline drinking, lasting out, I said 9 weeks, lasting out about 9 months after the treatment. So that was quite promising. It has been now replicated in a large randomized trial. This was in 95 patients, showing that people who got 2 doses of psilocybin with talk therapy, as opposed to 2 doses of placebo with talk therapy, are showing significantly greater reduction in their heavy drinking days and their drinking days in general. Of course, both groups are showing improvement. This was a 12-week psychotherapy, so pretty intensive stuff, so it works, but it seems to work better with the psilocybin. The plot thickens because now more groups are doing this, and this is from a paper published in Switzerland earlier this year, where they found with people who are dealing with some pretty serious alcohol use disorder, who either got 25 milligrams psilocybin with 5 weeks of therapy or placebo with the same therapy, there was no differentiation in the abstinence. And so 1 dose short therapy didn't really seem to do it in this study. Whereas, in this other study that was just published last week in addiction, really interesting, in a group of people with depression and alcohol use disorder, they did find in 30 patients that people who got 2 doses of the drug, along with their standard of care, were showing significant reductions in their alcohol use, compared to a placebo group. So there's still a lot more work to be done. I will say, Fred Barrett, who's over here, is doing a really nice study now, and this is Roland Griffiths, who I mentioned earlier, who helped really start a lot of this work. And, our group, Fred is now working on this large randomized trial with people with depression and alcohol use disorder in 90 patients. They just finished recruitment, and so now they're still collecting data, but from the open label phase, we're seeing really promising signal in the first 30 patients or so. Just, really consistent reductions, not only in their depression severity, but also in their drinking days, increased abstinence, decreases in biomarkers of recent drinking. So, we'll have to wait for the data to be finished, but it's looking very promising. Another promising area that we've seen has been looking initially in a small sample of 15 smokers for tobacco smoking cessation who got, they got 2 or 3 doses of psilocybin with CBT. And what we found in this 15, small cohort of 15 smokers was that 80% of them were abstinent at the end of the 6-month follow-up. And a couple of years later, we had them come back and 60% were still biochemically verified abstinent. Afterwards, we did a randomized trial, which is under review right now, but there's 82 folks in that study. They either got 1 high dose of psilocybin or nicotine patches. This was open label, so people knew what they were getting, but they were randomly assigned to one or the other. And just the preliminary data early on showed pretty good separation across the 3, 6, and 12-month follow-up, with 1 high dose of psilocybin outperforming the nicotine patch group. So we have a lot of these studies now showing antidepressant effects, showing promise in palliative care settings, and also in treating substance use disorders. So mechanistically, last few minutes, I just talk about briefly, what are these 2 sides of the coin? And I'll say, starting on the psychological side, there's something about the altered state that can be induced by these drugs that seem important. Specifically in the West, we typically tend to think of like awakefulness, dreaming, and sleep as sort of our canonical states of consciousness. But there are other ways of feeling and thinking that can be induced by various practices like meditation, fasting, sensory deprivation, or use of drugs. And these may actually have some utility, for instance, in what I think of as sort of destabilizing some of these unhealthy patterns that we're often stuck with in like a substance use disorder, and then allowing for therapeutic intervention. And so briefly, while people may have a certain set of behaviors, thoughts, emotions, and even a sense of self-identity that they carry around as, who they are and how they, behave in the world, when they're on the drug, these are shifted drastically. And that seems to allow for some ability to go in with the therapy and make some real significant changes in both behaviors and sense of self-identity, when you're working with a motivated patient population who wants to make some changes. I won't talk too much about the ethics, but I will just say, some of these qualities, specifically these unitive types of effects, have shown correlations with improvements in smokers and alcohol users in terms of their later reductions in their substance use. And so we think of these almost as sort of phenomenological markers of something that is helping people with their treatment success. This is from our smokers when we sort of asked them what stuck out to them from their dosing sessions and the treatments. People often would say things like, about spirituality, this sense of we are all one, this feeling that all is one. These are people who never talked to each other, they never met, but many of them are kind of describing very similar experiences. And I almost think of it as a sort of inverted trauma type event, because often, we have a very good sense for how a person can experience a terrible trauma on one day of their life that could have a lasting negative repercussion on their mental health, including ongoing symptoms like hypervigilance and so forth. And so we almost see a reverse here, particularly when people have these unitive type experiences where they're, on one day having these very big positive experiences that seem to help them in their recovery, often for a very long time. And so, we see these correlations, but obviously we can't tell whether that's causal or not. But it has been borne out kind of, fairly consistently. This is a nice, that big 233 person study showing that the more of these feelings of what they call oceanic boundlessness or emotional breakthrough that people reported during their drug session, the more of the antidepressant effects they experience later. This has also been found in ketamine, for instance, when treating people with cocaine use disorder, specifically the more unitive effects that people got during their infusions, the more improvements in their cocaine use. But same goes for ketamine for depression. So to me, this really speaks to the fact that the phenomenological qualities are important from a psychological standpoint. And briefly to wrap up, I'll just talk a little bit about the brain effects. And we see that these drugs sort of induce a chaotic state. There's a lot of activity and basically communication between networks that begins to happen when people are under the influence of these drugs. But that's acutely. What's interesting is post-acutely, again, after, this is a study done by my colleague Fred, a week later, a month later, you go back to the same person, you measure their brain activity using an MRI or some other imaging like EEG, which I'll show in a minute, and the brain is acting different. It's just, in terms of the way that it's processing information in the amygdala, the anterior cingulate cortex, the activity has shifted after the administration, and it persists, out to at least 30 days. And some of these changes that we see, from the drug are also correlated with things like antidepressant benefits. This is a cool study that was done at Yale, small study, but it was a fixed order placebo-controlled study. So the investigators knew that everyone was going to get placebo and then psilocybin in a group of people with depression. Patients didn't know that. So they got placebo, they had a little improvement in their mood here, uses their baseline depressive symptoms, and then it's improved after the first placebo session. Then they got psilocybin, and then you see this other drop, which is lasting at least 2 weeks post-session. Now, mechanistically, they also did EEG before and after placebo, before and after psilocybin, and then they compared the activity. And what they found was that after psilocybin, 2 weeks later, not a day later, by the way, there's this increase in theta activity. And so why this is happening 2 weeks later, we don't know, but it correlated specifically with the antidepressant effects. So again, something is shifting, biologically, and it may be going along with some of these psychological processes like enhanced psychological flexibility, enhanced mindfulness, which are also correlating with antidepressant benefits. The last thing I'll say before I wrap up is that, this is an early paper to look at this, but in 2013, these guys published saying, it looks like psilocybin may be causing birth of new brain cells or neurogenesis in the hippocampus of these rodents. That has since become a very hot area, this idea of what they call psychoplastogens or neuroplasticity inducing benefits of these drugs, which has now been pretty conclusively established in animal models, that we're seeing increased spine density after a single administration of psilocybin in areas like the prefrontal cortex of the various rodents, in this case I believe mice, and this is something that is also associated with things like lack of conditioned fear response afterwards, so they're able to unlearn a fear response more quickly. And so something about this increased neuroplasticity, which now has been measured out to 65 days after one drug administration of psilocybin, and you can see you're actually like looking at these new synapses and new projections forming off of the neurons, potentially is allowing for facilitated learning or unlearning of particular patterns. So I'll stop there. There's a lot of other data. I'll just say that there's a lot of interesting future directions. We're doing work with opioid use disorder, cannabis dependence. People are doing work with cocaine use disorder. And so there's all these other psychedelics that are not well studied, but we're hoping to get the ball rolling, studying some of these drugs to see if they work better or differently, or what we can use them for and in what ways. And so, this won't be necessarily a take two and call me in the morning, but I do think people will at some point in the next 5 years probably be able to go to clinics in the US and get these types of treatments by trained professionals. That I think is going to be a really interesting new direction for the field. So I'll just stop there and